Hello, my name is Minh Tran. I am a research associate at the Stockholm Environment Institute, Asia Center, based in Bangkok, Thailand. In this presentation, I am going to talk about an ongoing research that looks at health and biological hazard in disaster risk reduction, particularly at policy integration at the regional and sub-regional level in Asia Pacific, and the role of human rights and gender equality in policy integration. This research looked closely at policies and guidance frameworks developed by ASEAN, the Association of Southeast Asian Nations, SAARC, South Asian Association for Regional Cooperation, SPC, the Pacific Community, as well as regional offices of UNDRR and WHO. This research is part of the BRDR program, Building Resilience Through Inclusive and Climate Adaptive Disaster Risk Reduction. The BRDR program aims to support the development and implementation of innovative measures to protect development gains and enhance regional cooperation for gender equal and inclusive disaster risk reduction approaches. In this presentation, I will start with a discussion on the why of integrating disaster risk reduction and health policies, then on to the synergies between the two sectors, the current approaches to policy integration as reflected in the reviewed frameworks, as well as a discussion on gender equality and human rights in the disaster risk reduction and health policy nexus. In December 2019, a novel coronavirus first caught health authorities' attention in Wuhan, China. Over the course of 2020, it morphed into a global pandemic. Within the same year, the pandemic coincided with at least 84 disasters around the world, affecting over 50,000 people and resulting in 3,500 deaths. One of them was Cyclone Amphan, which struck India and Bangladesh as the countries were struggling with rising infections. Hospitals were overwhelmed with victims of both disasters. Emergency responses lacked due to pandemic restrictions. The cyclone was among the costliest disasters in the Bay of Bengal. Human rights and gender inequalities have compounded implications for health and well-being. During and after any disasters, burdens are unevenly distributed. Women often experience increase in unpaid responsibilities such as tending to the sick. Domestic violence against women and children grows, so does discrimination against members of LGBTQ+ communities during emergencies. Men are currently overrepresented in COVID-19 data. Women and children are subject to a higher level of stress and risk to their physical and mental well-being due to lockdowns. Furthermore, when hazards collide with the pandemic, these implications are further compounded. There are thus natural synergies in addressing gender equality and human rights in the context of health inequities and disaster vulnerability. The pandemic and concurrent hazards remind us that disasters stem not only from geological or hydrometeorological, but also biological hazards and their compounding impacts. Disasters and health thus go hand in hand. Against this backdrop, one must ask how countries and regions can build resilience to multiple hazards while ensuring the health of their communities. What is the extent to which existing disaster risk reduction policies address health risk and biological hazards? How do health policies contribute to disaster resilience? And how are gender equality and human rights taken into consideration in this policy nexus? To begin, health is understood as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And as a sector, health includes public health, which is the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. The overlap between disaster and health is clear when a disaster emerges from outbreaks and diseases like Ebola, MERS, or COVID-19. An ill-prepared health system worsens the condition of both those infected and those in need of other healthcare resources mobilized in response to the pandemic. Besides, flooding, earthquake, and other hazards also disrupt healthcare and health services, exposing people with medical needs to additional risk. The connection between health and disaster risk reduction has become even clearer with recent parallel paradigm shifts in both sectors. Disaster risk reduction has shifted from an emergency management perspective immediately after a disaster towards risk and vulnerability reduction prior to disasters. Public health has also gone from focusing on disease eradication in response to prevention and promotion. Health can play a proactive role in disaster risk reduction by decreasing health risk and vulnerabilities of a population and improving disaster outcomes. Health and disaster risk reduction overlap through the health system, risk assessment approaches, chronic disease management during disaster, mental health support after disaster, and public advocacy. So how are these connections reflected in current policies? The global context for integrating disaster risk reduction and health includes a variety of international agreements and framework. The Sendai Framework was the first global policy to substantially connect the two sectors, further operationalized by the Bangkok Principles for the implementation of the health aspects of the Sendai Framework. Arguably, the most important development recently in the nexus between disaster risk reduction and health at the global scale is the Health Emergency and Disaster Management Framework. The framework integrates systematic management of health risk into all phases of disaster risk reduction, marks a shift from a single disaster or public health only response to an all-hazard approach, including biological ones. In alignment, Asia-Pacific health frameworks and policies have increasingly adopted an all-hazard approach by expanding the scope of health emergencies to include all types of natural and human-made hazards. Policies take into account health risks from climate change, sea level rise, as well as sudden onset hazards like cyclones, floods, earthquakes, and so on, promoting public health awareness, addressing all hazards, and recognize threats for multiple, compound, and hybrid disasters. Similarly, policies in disaster risk reduction in the region foreground disaster preparedness through comprehensive hospital safety and disaster management plans, prioritizing health resilience through community resilience, school safety, reducing health risks through water, sanitation, and air quality improvement, and incorporating health and pandemic preparedness and response programs. Given those synergies, what are the approaches to integrating disaster risk reduction into health policies and vice versa? Current policies follow two major approaches. One is increasing collaboration and coordination across sectors. The other focuses more on infrastructure. Collaboration and coordination between disaster risk reduction and health, as well as with other sectors, are at the center of many regional and sub-regional health policies. Policies recommend integrating health concerns in disaster management plans, including health information in disaster risk assessment, aligning health services with hazard and risk profiles, getting health and disaster risk reduction offices to work together, and mainstreaming policies into sectoral planning. The other integration approach focuses more on investing in disaster-safe infrastructure to safeguard health outcomes of disaster, particularly critical health facilities through code of practice and design standards, school safety measures to address health risks of children, and safeguard schools as potential post-disaster clinics. The approach also includes enhancing knowledge and capacity regarding the resilience of health facility. Gender equality and human rights should not be overlooked in the integration of disaster risk reduction and health. Social determinants of health and root causes of disaster risk and vulnerability share common drivers, such as gender and social inequality leading to uneven access to services and resources, violations of rights, poor health outcomes, and thus vulnerability to disaster. Disaster risk reduction and public health management can address these critical issues in synergy. Policy integration that does not address human rights and social dimensions can further exacerbate existing inequality. However, except for policies that discuss gender inequality in health, few policies articulate a rights-based approach and a gender-equal approach to integrating disaster risk reduction and health. Human rights are often considered at the policy level, at the goal level, while gender inequality is often discussed as a driver of risk. In most cases, there is no detailed articulation of what gender inequality means or of differentiated risk across genders and intersecting identities. Nor do most policies interrogate existing power structures and root causes of vulnerability that inform health risks facing different social groups. None of these frameworks specifically account for the implications of considering gender equality and human rights when creating links or integrating disaster risk reduction and health policies. Nonetheless, policy documents, particularly at the regional level, tend to be aspirational and broad in their framing. It is thus difficult to assess how rights and equality are considered and implemented substantively and procedurally at the health and disaster risk reduction nexus. Furthermore, little is known about how they can best be articulated at the policy level to inform decisions and implementation on the ground. Further research, particularly at the national and subnational level, is needed to investigate human rights and gender dimensions of integrated health and disaster risk reduction policies and strategies. So the synergies between disaster risk reduction and health are well recognized in both regional and sub-regional policy documents. Policymakers see disaster from all hazards as a threat to health and health as an outcome of disaster risk reduction. However, the shift to a systems approach in health and a risk-driven perspective in disaster risk reduction has not been fully operationalized and integrated in these policies. Policies still often focus on coordination, cross-sectoral coordination in health emergency response, and in safe-proofing disaster infrastructure. Few policies consider the role of health throughout all stages of disaster risk reduction, particularly building health resilience and reducing health risk and vulnerabilities as an approach, as a strategy for reducing disaster risk. Furthermore, few policies address in detail how to tackle biological hazards or multi-hazards. In terms of gender equality and human rights, there is little discussion in these areas of policy integration. Whether or not rights and equality are actually considered in policy implementation remain unclear. Indeed, it is a worthwhile debate to be had around what are the most effective entry points for rights and gender action in the disaster risk reduction and health nexus. To wrap up, there is room for improvement in integrating disaster risk reduction and health policies. Future research and decision-making needs to go beyond increasing sectoral collaboration and safe-proofing infrastructure to really interrogate and investigate how we can shift the disaster risk reduction and health nexus in line with a systems approach to health with the risk reduction perspective in disaster risk reduction. A gender-inclusive and human rights-based approach to policy integration is needed to ensure equitable and inclusive outcomes. Thank you very much for listening.